Good morning, everyone. Thank you very much for attending this morning as we sort of bridge maybe fall into winter. I don't know. It's still fall because it's going to rain. Um, I'm very pleased this morning to allow us to present Marie Cloquer. She's a licensed social worker. Actually, had a little piece in NPR as was pointed out to me by Karen. It's an important topic about caring for the burned out caregiver. She's a clinical social worker with a dedicated focus on older adults and family caregiver work within the Division of Geriatric Psychiatry at McLean Hospital here locally. She founded and leads the hospital's dementia support program, which is so important, obviously, delivering both group and individual psychotherapy to strengthen caregiver resilience and to support people living with dementia. In addition to her clinical work, Marie's actively involved in research related to dementia caregiving. She also co-leads the division's diversity, equity, and inclusion efforts. Prior to her current role at McLean, Marie gained experience in community mental health settings as well as residential and inpatient care. She received her MSW from Boston College, and she's a licensed independent clinical social worker in Massachusetts since 2022. She has we have no other planner. The planners and the members of the Med Ed committee and the speaker do not have any disclosures to announce. So without further ado, I'll remind people also, please click on the link in the chat box when it pops up later in the program to receive credit. And any questions you have, please go ahead and put them in the chat box. Make sure you mute yourself and turn off your camera. All right, Marie, take it away.
Thank you so much, Dr. Sidebottom, and thank you for hosting me here. I'll be speaking about a topic that I work very closely with and care about a lot, is caring for the burned out caregivers. And I'm focusing here primarily on family caregivers, although we could argue that any of us in the healthcare field could consider ourselves caregivers as well. So for run of show here, I'll be taking us through caregiver burnout and its relevance to healthcare. And then I hope for you all that we make it pretty practical of some take homes of what you can do for caregivers, both in the moment, in just a snapshot, in the kind of doorknob comment you might have with a caregiver, all the way through if you have more focused time, or even as you're planning your own intervention, perhaps an ongoing way in your clinics. And then put what you might do on your front line in the context of that macro, larger caregiver initiatives that are happening at this time. So for caregivers, we are talking about a lot of people. Caregiver here, the definition is, again, I'm thinking mostly family caregivers, although about 10% of unpaid caregivers in the US are caring for a friend or a neighbor. But someone is providing care, which could be as instrumental activities of daily living, like shopping, transportation, or direct personal care, like bathing and the personal direct care, ADLs, as well as some of that medical care, like monitoring symptoms, dressing wounds, caring for an adult or a child with a medical condition or a disability. In the past 12 months, there are 63 million caregivers under this definition in the US. So caregivers of someone with a condition or an older adult, as opposed to parents who are also caregivers, but not in this kind of role that we're talking about here. And so caregivers, because they are often caring for someone with a medical condition, they are our very, very front line of healthcare. They hopefully come to our appointments at the cadence that we set, but they're the ones who are providing care to the person who needs to be coming in for the appointment. And related to my work with older adults, most of those caregivers, 59 million of the 63, care for an older adult. And just to get a sense of what we mean by caregiving, it's calculated over the last year, but caregiving typically lasts for something in an average, or 30% are in that role for 5 years or more. And for some of the more chronic diseases or degenerative ones, like dementia that I specialize in, that care can go on even longer. And what we see with these numbers also is that there is a very rapid increase in the number of caregivers. In the last 10 years, we've increased by 20 million caregivers from uh, in 2015, 43 million, 2020, 53, and now at 63 million. Of those, two-thirds are women, and the average age is 51, which may surprise people that it's a little bit it's younger. About a third of these caregivers are sandwich generation, caring for a younger generation and the older. And so we're talking about caregivers, and when we talk about burnout, it's because there's a heavy burden, and it may come as no surprise to anyone, but there are many, many factors to this. There's both the heavy logistical burden when I meet with caregivers. That's often one of the first things they talk about. They're caring for appointments, becoming the keeper of the social calendar if they haven't already. They're, again, providing some of those medical um, oversight of their person, safety concerns, medications, as well as financial strain for paying for some of these issues, as well as lost wages for caregiving. And alongside the logistical really comes the emotional burden of caregiving. And I just, took one day of my caregiving clinic and wrote down some of the emotions that folks share with me. Exhaustion, frustration, guilt is a huge one. And I want to also pull out highlighting loss and grief of both the life that they maybe hoped for their loved one, but also the loss and grief of what they may be losing right now. And it's an ambiguous loss in that the person's still alive that they're caring for. It's also a disenfranchised loss in that it's hard to measure some of the losses that take place incrementally or those events missed or opportunities missed, as opposed to when someone dies and people show up with a casserole. So these heavy, heavy burdens of caregivers indeed translate into outcomes. So for caregivers, compared to their peers, matched for age and other circumstances, caregivers have higher rates of negative outcomes for their physical health on measures like frailty, cardiovascular disease, uh, heart disease, cancer, and stroke. And on the mental health side as well, there are higher rates of depression and anxiety, suicidal ideation, and prolonged grief disorder, so that even when their loved one dies, there is a higher risk, even after that death, even after the kind of day-to-day burden is gone, that caregivers continue to hold. And we know that if a caregiver is sick, they are going to need more health care, but it also means that the person they're caring for is less likely to be getting the care that they need. And, we have a name for this when a non-medical factor plays a huge role in their outcomes of health and well-being, and that is social determinants of health, or I usually use social drivers of health. They don't quite determine us, but they certainly play a huge role. And so if you take nothing away from this presentation except for this slide, caregiving, because of the outcomes that are associated with it, negative health outcomes, is a social driver of health. It fits under the category pointed out here of social and community context. So just as we think about access to healthcare, access to clean water, discrimination as all factors in people's health, so is being a caregiver. And for some of the diseases, like what I treat of dementia caregivers have even higher risks of these negative outcomes. So caregivers are both, as I pointed out on that first slide, the front line of healthcare because of the care that they give to their loved ones, but they also their role makes them vulnerable to becoming having needs for healthcare themselves. So we've talked about caregiving and alluding now to burnout for burnt out caregivers. The symptoms of burnout for someone is a culmination of emotional exhaustion. Often they display depression and anxiety symptoms, trouble with sleep, fatigue, social isolation, reduced sense of personal accomplishment. So both the physical symptoms, but then it gets into really that internal state for somebody. But when we talk about burnout, it's helpful to look at it on this continuum of stress that we hopefully spend time in this green level of being ready for the next thing that's coming for us. We can feel motivated, and for caregivers, often that's a sense of purpose, and that they can even find joy even when things are tough. But the next part of the continuum is stress. And I throughout the day we often cycle from green to yellow, back to green to yellow. And this yellow stressed state is a transient state. We can certainly feel it of in our emotions of irritability or feeling down. And things like sleep difficulties or not feeling as focused happens to us. But again, this is a transient stage. Where we start thinking about burnout is when these symptoms become persistent and turned up in volume. So that I'm not just irritable, but actually had an outburst or even an extended period of time out of the emotional range that I'd like to be in and trouble getting back. And these down moments then turn into a burden that I'm carrying around of excessive guilt where I can't quite shake it. And this burnout is a place to really be highlighting because it's the last intervention before we really fall ill into those strong, serious health outcomes that I mentioned earlier of clinical disorder, whether that be physical or mental health. And it can cause impairments on your ability to function. And this illness is really what even worsens over time rather than abating. So just as a continuum can get worse and worse, switch now to the hope here. And that is that with intervention, we can help people go backwards on that continuum to get back to wellness. And as Dr. Sidebottom mentioned in my kind introduction, one of my focuses is on caregiver resilience, that the risks are very, very clear, I hope by now. But with intervention in helping people tap into the spaces of resilience, purpose and meaning of doing right by people, of being a helper, of being proactive, of being even selfless. When we tap into those virtues as opposed to allowing the pile up to slide into vice, then rather than just what we typically think of as a downward spiral, indeed the spiral goes up too, where both mood and one's world can open. And in the longitudinal work I do with caregivers, in fact, this is what we see, and this is a great hope for us, and why thank you for attending this presentation, that with support, in fact, caregivers can hold more than they thought and can make decisions that stay true to their values and the sense of integrity, so that in their inability to do everything, their limitations, we find them actually reaching out for support from other people. They're in creating social connections, um, getting good at asking for help, trying to not take things too seriously, finding humor even in moments of difficulty. And I'm happy to say that the caregivers that are in our care, for the large part, become the kind of people that we would like to be when we're faced with adversity. More flexible, more creative, compassionate, and tender. And this is kind of the opposite mark of the risk of caregivers, that they become downtrodden and burdened and sick. What if actually the intervention, they become more resilient? So that's what I'll offer us today and lead us into what I hope will be very practical about what you can do for caregivers. And this are I've offered some points of entry for whatever your role is. So for these points of entry, I wanted to give a visual. Here we have a little road, the caregiver journey. And I've called this level one of encounter. If you just have a short encounter, you're in an appointment with a caregiver. Or some of you, many of you, probably follow people on an ongoing basis. And I think about that as accompanying, that you are seeing them periodically through their caregiver journey, even if you're not specifically caring for their caregiver needs, you have an ongoing relationship. And then some of you are in positions of maybe overseeing a clinic, um, or running your team. And in that position, you may actually be able to strategize based on the high level of number of caregivers we have and they're real crucial part of our caregiving system, that you can strategize about how you might intervene on a more ongoing overview basis. So starting with this level one, this is that you are seeing this person and you're in an appointment. I have a very, very simple intervention here that you can use of recognizing the caregiver burden. You've attended this talk, and now the light bulb goes off. You have someone in front of you. The average age is 51, so we're really running from 40s all the way through end of life, and more often women than men, but we really don't know. And so I hope that because caregiving is a social determinant of health, this can become a routine to ask this first question. Are you a caregiver for a family member or someone in your community? First, just asking is how we get to know whether someone carries a risk, in the same way that we have standardized through many practices asking for social determinants of health, access to medication, finances, transportation, housing stability. This is a question we should be asking. Are you a caregiver? And from that, if they say yes, caregivers that I talk to often take a lot of consolation in knowing that they're seen and that someone has some kind of inkling of what they're carrying, of that slide earlier of the caregiver with two hands of holding both the logistical and the emotional. And I leave this up to you of where you feel comfortable, but you could even use a very simple stock phrase of recognizing their role of just saying caregiving can feel good and provide purpose, and it can also be difficult. It can also be taxing. And here you could certainly ask an open-ended question, like, how are you doing with that? But we don't always have the time for that. And if you really want a snapshot, one distilled question that I use is, if nothing changed in your current situation, could you continue to care as you do for another month, 6 months, a year? You can kind of choose your time frame there, because it gives us kind of an immediate sense of where are they on that spectrum of I'm good green, I'm stressed yellow, I'm burnt out, or I'm really close to burnout orange, or red. Would hopefully would see other signs as well if they are indeed ill. And oftentimes we don't ask about these things because we don't know what to do. If I ask, we have an obligation to be able to provide something. And so on this next slide, I'll give you a couple, just like the most important or the quickest resource you can have. And so, asking how do they feel, and then say, I have a few resources for caregivers. Would you like to hear about them? And this is another way for you to indicate to those under your care that you know something about caregiving, even if it's just a little, and you care about it. And from your own standpoint, you take it seriously as a social driver of health. So in Massachusetts, we have a family caregiver support program, and it's statewide. I pulled this right off of the mass.gov website, literally screenshotted these little paragraphs. And so they are open to you at any moment. And the family caregiver support program is for unpaid caregivers. There are two kind of eligibility. One is for anyone 18 and older, caring for someone who is 60 plus or has dementia from any age. The other eligibility for this is that the caregiver themselves is 55 or older and caring for a child under 18 or an adult with disabilities from 18 plus, which covers a lot of caregivers. And the way to connect with this caregiver program, it's funded through the state and uh, given by the ASAPs, the Area Service Access Points in across the state. There are 24, if you're not familiar with an ASAP, they have a catchment area. There are 24 catchment areas in Massachusetts. You can very easily find which ASAP serves the place where your caregiver patient lives. Again, on mass.gov has a list of all the towns and their corresponding ASAP. There's a little map here that shows the catchment areas. So they run the caregiver programs, and they also have a dedicated line for information and referrals so that you can either yourself get some of those basic resources, things like if you wanted your office to have a list of local home care agencies for respite or day programs for people who are under the care of a caregiver, that would be a great place for you to have, either for yourselves as a clinic to hand out or to direct a person. And if you were to make a referral to the ASAP or the person were to call, one of the things they would do is come and do a home visit to assess. And so it's not just on you to do this. This is a your kind of next line of defense for any caregiver that you see. Again, you can find these on mass.gov. And so if we go into intervention level 2, as I call it, that you are someone that has an ongoing relationship with someone who you know to be a caregiver, you're accompanying them. And so it gives you a way to kind of track this and to get a bit more information besides just that snapshot and resources. And so this is often how I accompany people. So this is probably my busiest slide. I want to point out that in the annual Caregiving in the US report that the AARP puts out every year, caregivers are asked to select, and they can select multiple, about what are their top priorities for getting help as a caregiver, where they need more information or more support. And managing emotional and physical stress is number one. It's the most common that they select of any of them. And so we should always ask people what they need, but that's likely going to be one of the top things, is the emotional support, and as well as resources, of course. And so I've kind of distilled out the literature and the work that I do in supporting caregivers. And this holds true for caregivers, it holds true for frontline healthcare workers, for stress management. If you can send someone into a difficult situation with only one thing, let it be connection with another person. So interpersonal support. And there are kind of two ways that I think about for caregivers. The high level of depression, of guilt. One of the best ways out is to latch yourself onto to someone else, to have them mirror back to you who you are, as well as to remind you that you're more than just a caregiver. And so uh, there's a higher level of behavioral activation, kind of starting the reward system, as well as the decrease in depressive symptoms with this one-on-one interpersonal interaction. So I often have people think about, is there something you can do with a friend? And when you're giving someone some tips this kind of friend, if you're looking for directing them towards someone who's really going to be helpful, the ideal friend is someone who's emotionally fairly stable, a good communicator, and fairly organized. And you can imagine those things are so that the friend and interaction doesn't become hopefully more of a burden on the person. And then the second way for interpersonal support is support groups for caregivers. They can be found again through those area service access points from the previous resource. Councils on Aging and senior centers have them, as well as there are many disease-specific groups. And the one of the great things here is there's a high level of, as I mentioned, guilt and also can be shame around caregiving. And the antidote to shame is not, it's okay. The antidote to shame is, I've been there too. And that comes from these support groups. The other part of caregiving that if you're seeing them on a kind of longitudinal basis, that you can be encouraging along with that interpersonal support is the growth mindset. There's a much higher correlation of caregiver resilience when it's paired with self-compassion. And that starts with the idea not I'm good, I'm bad, I'm doing enough, I'm not, but how am I incrementally getting better or changing my direction? And so, when caregivers say, I'm just not good at this, I'm not good at asking for help, I say, well, of course you're not good at it yet, because you haven't done it for very long, or you're just trying this for the first time. And so, taking on off that morality, good, bad, or black and white and into the gray is helpful for people to start to shift their mindset. And with practice, they do. And for anytime you're asking them to do something different or to consider getting help, I always frame these as experiments that, well, you've never tried to have help before, or you've never tried to take a day off for yourself or bring someone else in. Why don't we try it and see? In this relationship where you have a little bit more time with the person, you know you're going to see them again. Well, we don't. I didn't put this in the first. It could though be in the first level. But as I mentioned, caregiver suicidality, or at least suicidal ideation, is uh, is higher for caregivers, and so I make it a matter of routine, especially for caregivers that I know I'm going to see in an ongoing basis, is to ask early and to ask periodically about suicidality. And I use the CSSRS, just these two questions. Many of you may be familiar with it. In the last month, have you wished that you were dead or wished that you could go to sleep and not wake up? Of course, that's just ideation. And then the next question, in the last month, have you actually had any actual thoughts of killing yourself? And you may be surprised, well, you may or may not be surprised that in asking the question, we hear that people's burden level may be higher than we thought because they are actually screening in on the CSSRS. And the last thing to be asking about with people that you see on a regular basis is also the flip side of risk, which is resilience of how are you doing this? You're hanging in there. And so asking them about sources of strength and purpose and meaning. So I think of this as kind of more of a menu than that you have to ask these things every time. But these are things that are not too hard to track of, are you seeing people? Um, Being gentle with yourself, trying things to make it to bring back that sense of efficacy, suicidality, and then sources of strength on this journey, which, as we know, can be quite long. For this, yeah, I know this may be a hard slide for you to see. If you're seeing people on an ongoing basis, one of the things that happens is, or that happens to me at least, is moments of feeling like I'm stuck. I'm trying to help the caregiver, and they're saying like, I'm good, we're good, we don't need any of those things. And I'm, not quite sure that that is truly their state. Um, there is a caregiver readiness scale done by the wonderful Laura Gitlin and her colleague Pearsall, that this one is adapted specifically for dementia caregivers and breaks into four different stages. But if you're familiar with motivational interviewing, you'll also find this language somewhat familiar. I'll just, because it's hard to read, just read out a couple of lines here so that you get a sense that indeed we as providers can tailor our approach and moderate our own distress around really wanting to help a caregiver by following this kind of rubric, which again, this one is for dementia caregivers, given my work, but it can easily be adapted to other scenarios. And the first question is, does the caregiver know and acknowledge the person has dementia? If no, they're in a pre-contemplative state, pre-contemplation for a behavior change. And they're saying everything's okay. Oh, they're just old. He's being manipulative. And so, myself, as someone who's looking to intervene, I'm probably not going to directly ask this person to make a change. Instead, I'll start with some education to help them make it more metabolized within them about the reality of the situation. And certainly, person-centered care, is there anything that they would identify as how can I help? What are you interested in for learning or knowing more about? To just kind of meet them where they are and see if I can move them anywhere. And that's kind of in contrast to um, this question, does a caregiver indicate willingness to try an activity or different strategies? And if they are trying, then what you'll see is that they're open to listening. They're going to ask questions for that engagement of back and forth. And that would indicate to me like this person is pretty ready. And what I would start to do is probably actively engage them in problem solving. Um, and even help them identify activities and then hold it as saying, I'll check in with you the next time we see each other, even if that's not for 6 months from now. But I'm not going to try that for kind of the earlier caregiver who's maybe not ready. And it's not a moralistic judgment. It's just also to use our own strengths and bandwidth where it feels most efficacious. And then for level 3, and I'll spend the least time here just because I hope that some of you may be in a position to strategize and to look over, but many of you may be more front lines. So just a taste of kind of the world of caregiving and interventions. One of the big questions that we have with caregivers, especially with this huge boom, again, 20 million more in the last 10 years, and with older adults, the continued rise in that demographic, we will continue to see more caregivers. And one of the questions in many of the caregiver interventions is we have to see like, do interventions work? But part of the question of collecting data if something works is to ask, well, what are we measuring? Like what do we really want to see as level of change? And the most common caregiver scale that's used is the Zaret Burden Index. And I'll just give you a snapshot of part of the short version of the Zaret Burden Index. And why I have a little bit of hesitation around using the Zaret Burden Index, even though we do use it for one part of our clinic, which is that it asks these questions. Do you feel, for instance, do you feel strained when you are around your relative? Do you feel your health has suffered because of involvement with your relative? And there is, I think, in this wording, inadvertently trips up caregivers not to think just about their role as caregiver in giving care, but also ties in with the emotional guilt and ambivalence around both wanting to care for their probably loved ones, someone they love, but also feeling burdened by them. And so I have found this not always to be an accurate screen, even though it's the most common. And therefore, when it's common, people can compare it to other studies. So they want to use it. One that I prefer, if we're looking really at burden, to try to track how far are we going towards burnout is the burden scale for family caregivers, which comes out of Europe and is translated into many languages. This one just has a slightly different touch to it because it says my life satisfaction has suffered because of the care, as opposed to the person with whom I have a relationship. My health is affected by the care situation, or the care takes a lot of my own strength. So I found this one to be a bit more accurate for those of you, again, who are maybe thinking, gosh, we have a lot of caregivers, we might want to track this and how they're doing. This, I personally have a slight preference. It's also validated. But the question that I started with or alluded to earlier on is, yes, there's caregiver burden, absolutely important and leads us to see risk, but what about resilience? Because so often what I find in caregivers, dementia caregivers, dementia is not any easier for the caregivers who end up being resilient, but it is about identifying those strengths that have helps them to get that way. And so, a different way of measuring health of caregivers is not to look at risk, but of resilience with caregiver efficacy. So, I've pulled one of the scales here, which, again, the wording is different. How sure or confident are you that you can stop yourself from thinking about unpleasant aspects of caring for your care partner? How sure or confident are you that you can stop yourself from worrying about future problems? And so, as opposed to I'm always worried, like, how can you stop yourself? Because it also gives this insight to the caregiver of this is the muscle I'm building, where even if the weight of what I'm carrying doesn't decrease, such as in dementia, where the care needs only increase, what is the muscle I'm building that I'm becoming more resilient? So from here, I'm going to pivot into this last part about what are the caregiver support programs that already exist. Um, because what I've just described is kind of what you're doing on the front line, what you may be doing or may consider doing. But at the larger scale, there is this growing understanding and recognition that caregivers are the front line of healthcare, that there are more of them, and that we need them to be well for healthcare to work, as well as for their own well-being. So, a couple of things just want to point out. One is financial programs that do already exist for caregivers, although there's certainly discussion at the state and national level about are there tax incentives for caregivers or ways to make their informal, unpaid role paid? So these are things that have already existed, but just to bring them to your attention. One is the Medicaid benefit, the home and community-based services benefit, in which a a family caregiver or it could even be a neighbor for someone who is a Medicaid recipient or beneficiary, they can appoint someone as a caregiver. It's a modest income, about $40 to $50 a day or $1,500 a month for this person as a way to offset the costs that it would be for Medicaid to have this person, for instance, in a nursing home or a higher level of care to keep them in the community. And then the VA program for comprehensive assistance for family caregivers also has a benefit. Medicaid eligible, but through VA of a similar kind. Another a realm of caregiver support that's happening, becoming more popular. I've just listed a couple here that I'm familiar with because from my own system. One is the program that I run of caregiver therapy. So over at McLean Hospital, rather than just treating the caregiver as an adjunct to the patient, so through the patient's appointment that we talk to the caregiver. In fact, we've actually brought caregivers into our clinic as patients themselves so that we're really able to address those psychological needs through primarily group psychotherapy. And we separate out spouse caregivers from adult children caregivers so that we can more finely attune our interventions to their emotional and relational needs for this. And what we found is it's quite efficacious in that you can give someone resources, but if in fact it's more of the emotional, relational, psychological barrier for them, then if we just lower that barrier by addressing those psychological needs, then they can just activate on the resources. So efficacious in that sense, as well as McLean's a psychiatric hospital, so it fit with the kind of perspective that we have. And as well as the MGB Choir Caregiver, the Center for Health Outcomes and Research. They have a caregiver clinic that focuses on caregivers of adults with neurological disorders. So still a subtype of caregivers, but nonetheless a caregiver clinic. And they offer both individual and group therapy. And now on this is such a big problem that really we need a scalable solution. And there's so many companies and organizations that are getting into startups that are getting into the digital AI powered support for caregivers. Some of these have insight from the medical field, and some of them don't. Certainly well intentioned. We get approached by so many of them here at McLean that I didn't even dare risk putting some up there because there are many. But the big question here is they need vetting for clinical care. Do they actually make a difference? And there's really the question about AI versus human. AI can do a lot of things and large language models, but we really need to know what are they good at and where is a human best in the front, or should a human be backed, be using the AI as a helpful tool themselves, kind of like augmenting the human aspect of that. And that is something that this question of what is AI best suited to do and what is the clinical impact is something that we're actually studying in a small way at McLean Hospital. We got a grant from the Mass AITC, which is the uh, Massachusetts AI and Technology Center, uh, a grant through the NIA to study presenting questions to caregivers, and we gave them three answers. One was just from the large language model AI, one was from just a human, and one was the human having access to the AI and seeing which of those three answers the person liked best, as well as comparing the subcategories of resources versus advocacy versus disease education versus emotional support. We don't yet have all that data collected or calculated out yet, but we will, which we hope will give just at least a little bit of information of what can be done at a larger scale with incorporating AI. And then these last couple um, models before we break into questions is a very exciting change at the national level that really recognizes, again, what I've been saying, caregivers are on the front line of healthcare as well as their own health. And starting last summer, 2024 summer, Medicare, CMS, released the GUIDE model, which stands for Guiding an Improved Dementia Experience. And this is a Medicare benefit with no cost to enrollees for folks who are enrolled in Medicare A and B as their primary insurance. It's an 8-year pilot for, again, dementia care. And this is aiming to be the new national standard for dementia care. And what I want to really highlight is that for up until very, very recently, all of Medicare, the largest healthcare payer in the world, would treat a patient, but the caregiver is really adjunct to the patient, even though we know from our day-to-day interactions that caregivers are integral part of the patient's well-being. And so with this guide program, this Medicare benefit program, anyone who's delivering the guide model, McLean is one of the sites, one of 330 around the country and 15 who deliver care in the Massachusetts. We're now, through this model, paid to care for the patient and for the caregiver. It is mandatory that the caregiver gets support, access to support and disease education, as well as the helping support the non-medical role of the caregiver with care coordination to help manage the the very complex medical system that we have, as well as resource navigation for services that would be helpful to themselves and to their loved ones. And for also the first time, Medicare actually has an allowance. It's a small one, very modest, $2,500 for the year, which ends up being about 74 hours of in-home care at their rate for the year. But it says caregivers are so important. We're not only going to treat them and support them, but we're also going to give them respite, which is what caregivers ask for over and over again. And our studies, decades of studies, have shown that that is one of the ways to help support a caregiver going, coming back from that green, yellow, orange, red. Respite is a way to help slow the progression and actually get someone back closer towards the green. This is being paid for by CMS. But I also just want to highlight right here at home at Tufts Medicine Memory Care is their own, the guide program is a national model, but there are many, many programs that are coming up. And again, I wanted to highlight here at Tufts, the Memory Care program, which provides very similar experience for dementia caregivers to the guide program, kind of its own brand, led by the wonderful Dr. Brent Forrester and Caitlin Ruvette here at Lowell General. And so I, with that, just want to recap that being a caregiver is a social driver of health. That's all you take home. That's a great one. And not to lose sight that caregiving also has resilience factors of meaning and purpose. You can certainly support caregivers even on a short medical visit, just a quick identify that they're a caregiver, offer one support, and that the number of caregivers are growing extremely quickly, will continue to grow, but there are some programs that are coming up that we're kind of can help ride the wave. So I'm now open for questions.
Well, thank you very much. It's a very relevant topic for a lot of people. And I think even sometimes it might be difficult for a person to even label themselves as a caregiver because maybe their take on it is, I'm just doing what has to be done, and I'm not, it's nothing special. And certainly there's a lot of chronic care issues involved. I just saw a patient last week, C5, 6 quadriplegic. His wife does all his care with it. So there are like long-term issues that are there as well. And certainly, I think the point about people asking for help, people might feel represents a failure on their part, which there really isn't.
Right.
And the other point I was going to make was as well, because there's one question here too. But I think one good part about asking how you're getting through this and what tools do you use almost empowers a person to help other people. So and you could pose that question, I think, saying, well, how are you getting through this? Because I have other people I could help if you have some tips and tricks I could share, and all of a sudden, they feel empowered and proud of what they're doing, and everything well too. So
Yeah, thanks, Dr. Sidebone. That last point is really important. What I the risk of say caring for burnt out caregivers is that we can actually overemphasize their risk and almost disempower them that they're always in need without recognizing that in fact they're giving quite a bit and it's pretty amazing. Um, and so one of the things when I am bringing someone into a caregiver group is both to highlight, of course, I hope that you get some help out of this. But what I will preview for them is that what I see over and over again is that caregivers, when they're in a group, just like you said about feeling empowered, is that they will actually see in their own responses to one another that they've learned quite a bit, that in fact they've changed quite a bit from when they started. And this is one of the ways that they kind of become encouraged, as well as can feel that at the same time that there's a heavy weight, as I've said, there is also great strength. And I can't tell you how many caregivers that I see come out of this saying, of course, I would have loved for my loved one to be in better health or to have not had this condition. And yet, I'm proud of who I've become. And we can't put uh, a value on that of how they get there. And but it my emphasis here really is that that change from high risk into resilience comes most efficaciously when there's support, when there's recognition. It's really hard to do that on one's own. Um, and so that's where we can play a role here in the healthcare system.
Sure. I'll remind people to receive program credit and review the excellent talk. Please click on the link that's been posted in the chat box. One comment, practical management point, activation of parasympathy. Please comment.
These are not um, terms that I'm super familiar with, which I'm gonna look up. I wonder if activation of parasympathetic system might be.
Yeah, I don't. It said parasympathy, so I don't know if
Yeah,
that's.
right. Yes, I see the comment. Um,
Yeah.
so um, I
Well,
am, yeah,
while you're
not,
thinking about it, I would
yeah,
also say, I mean, I meant to mention in the introduction, exactly as you mentioned at the end, that you do offer assistance with the neurological team here at the memory care at Tufts as well, which is so important and an increasingly large portion of people's population, especially PCPs and everything as well. So, and I don't know if Dr. Singh could or the commenter could clarify the question that they posted. So.
yeah. Um, what I will say, I guess, on the nervous system is that some of the work that's being done with caregivers, again, many trials and interventions with mindfulness and breathing to help people move from an activated state into a calmer state can be pretty powerful. That one of the things that happens for a dementia care or for a caregiver is this loss of self-efficacy that I described, but also loss of sense of control because they're caring for a person, their health is out of their control. And so anything that gets a caregiver to come back into their body, could be breath work and mindfulness, is also a way by which they start to feel physically in control and then mentally in control to find ways that they can be productive of making those choices, as opposed to what I can often see in caregivers, and those of you who have treated caregivers can see there's sometimes this like frenetic pace as if there's always the next thing even if it doesn't really solve. So I see in dementia folks who say, really my loved one probably just needs a different kind of wheelchair. And, and unfortunately, it's like probably not what they need. Probably what the caregiver is noticing is that there are real losses. And it's more it's avoiding the emotional topic of grief and loss and instead pointing to these kind of like outward things. And anytime we can get caregivers to be back in touch with their own bodies and their feelings, they'll be more likely to be able to use a compass to decide like really what is the intervention that I need to be doing here.
Sure. Well, and I think even raising the questions, even the part of the primary care or other professionals in asking about observations of what's being done, how could things be improved in some respects, both for the ease of the caregiver as well as the patient. I mean, basically leaving the door open to the caregiver to offer suggestions, and maybe there's a way to seek some help in engaging from a physical therapist. Somebody else might have another idea and another tool in the toolbox for sure.
Absolutely.
Yeah.
Yeah,
So
just that what you're describing of helping to feel to give the let the caregiver know that you've got some skin in the game too, and you'd like to help problem solve so they don't feel so alone.
sure.
Is a huge thing. And that someone I can't tell you how many times a caregiver will say, it's not my PCP, and they asked me about how I'm doing as a caregiver. and they said I felt like they got it. Um, and it makes a difference. I also have people who say, I talked to my doctor and they said I need to take care of myself. Well, I'm trying, like, but at least they remember that you've asked. They
Mhm.
remember that you've told them, even if they feel frustrated, like they don't know what the next step is. They know that you've seen them, and that is a lot better than the alternative. As well as for when someone is for they maybe they need something like surgery, someone right now who's going in for surgery, and just to know that their provider said, I know it's going to be hard for you to schedule because of your caregiving duties. Is there anything that we should be thinking about? It makes a difference. So
Sure.
thanks. I know that you all are um, again with the TUPS program. The one that I do know about is doing his best to make keep caregivers at the in the heart of care. And I hope that this was could add to some of those thoughts that we all have.
Sure. Well, and even I guess, can you comment a little bit on, I'll mention also, please click on the link in the chat box to review the program and receive credit. Can you comment on the change in the system to reimburse family members as PCAs, assigning those PCAs, and then some financial reimbursement? Because acting as a caregiver in that sort of a setting, certainly all of a sudden that person is taken out of the workforce and they're lacking income to even provide anything. How is that actually done? I was curious, and how does a person go about being assigned as a PCA, even though they're like a family member?
Yeah, so that program is actually not new. It's been there. It's, I think, very practically speaking, if you want help with that, then using the ASAPs as a main resource, they do this a lot with folks. Um, but not a super complicated form. I think you can't be a spouse, but you can be many other family relationships. The person being cared for does have to be on Medicaid or Medicaid eligible if they're a veteran. Um, and there are actually a bunch of cottage industries that are if you just Google become a paid family caregiver in Massachusetts, there are actually services that will help with at no cost to you, help you sign up for this, so that you don't have to do it on your own. But this is part of a larger question that indeed, as you discussed, Dr. Sidebottom, that um, many caregivers lose wages for having to leave their work or reduce their work hours. And we do not yet have a comprehensive way to recognize or to support them. So there are uh, kind of nonprofits or organizations that raise money to help provide some respite care. Not nearly enough. It's a band-aid. Um, but the larger discussions that are happening at the national level around, for instance, either tax reductions or direct pay for people who are not on Medicaid, or to increase the rates for family caregivers is something that needs to continue to happen.
Sure. And yeah, one of our nurses said, "Thank you, Marie. You're a wealth of knowledge and appreciate your guidance." So I would echo that for sure in terms of the presentation. It's great that you also highlighted the resources and how to tap into the resources that are available for the caregivers as well. So, and certainly I know our medical staff and the part of Dr. Joseph and our spiritual support team offer wellness programs also for our physician staff too, who may also double as caregivers themselves too,
Definitely.
for sure. So,
Definitely. Yeah,
yeah,
caregiver burnout for the medical professional even in your professional caregiver role is real and definitely a lot of overlap between what we see in family caregivers and professional caregivers. So we're human. That's the
sure.
bottom line. And there's something it can be taxing, but there's also something very humanizing about caring, which is, again, that caregiver resilience that I want to tap into of how important it is for us to help people care in tender ways for one another. Thank you.
Sure. Yeah, and I think one of the complicating factor I just mentioned as the last comment is, and I know I've seen this myself, family dynamics. And you might have
Oh yeah.
multiple children, and then one person supplies the care doesn't receive support from everybody else, but is also the butt of comments, that
Yep.
and complaints, even though nobody else is providing support.
Absolutely. Yeah, this is something where, again, our caregiver therapy program becomes so in handy, and the guide program that follows people longitudinally because we can help caregivers to untie those knots of that almost always come up. And that's something that especially psychotherapy can kind of lend itself to, although certainly others and other disciplines can do that too. But that can be kind of a something to delegate to folks when possible.
Sure. Well, thank
Great.
you very much again. I'd remind people to click on the link in the chat box to review the program and receive credit. I think time is done. So thank you very much for your excellent presentation, and we look forward to you coming back and refreshing our resources.
Thanks everyone for coming. I really appreciate the invitation and glad to see you all. Have a
All
great day.
right, thank you.
Bye.